emergent care, like, evaluation of soft tissues, pulses, etc. We got to get these reduced. That's why we'll take these to the OR to X-fix this, and this is, you can just see how this is in varus here, where the medial side, the distal part of the ankle is medial or towards the medial malleolus. So this is something we want to make straight. Orthopedics is not complicated. We want to make that leg look like a leg again. Open fractures, we talked about it a little bit, that case that Nick, has here, so this is something, many of these are open, they're higher energy, this is, and I think what I've started doing too is using some of the calcium sulfate with antibiotics for some of these cases, when I definitively fix them or even stage them. I don't know, Nick, are you using any of that?
Not that often. I get, there's been some issues with just drainage from some of that. And so I tend not to. I might use vancomycin powder or something like that, but probably less likely to use the beads.
Gotcha. Yeah. No, I've been a little bit more aggressive about using it intra in the bone, actually. So hopefully then close it off, right? But I won't put it right under the skin.
Yeah, that makes sense.
But
you got to put it in there before you reduce it, right?
I mean, usually you have like a whole, you have a gap or something.
Yeah,
so I'll just like inject it.
Yeah. Okay.
But I think that has been helpful, and there's some studies coming out that are showing that might be an effective way to reduce infection for open fractures. So it's something, just if you have that available as a rep, I mean, I would look up some of that stuff, or I can share some of the case studies that have been done, and I think it's a helpful tool for the surgeon, to easily put in local antibiotics.
Jan, is that something you were, as you're prepping a case, you'd want them to kind of have available as an option? Would that be helpful for you? I mean, you're probably going to communicate that beforehand, but
yeah, and I think they know that already where I'm at. So it's a little bit different. We deal with a lot of open fractures, but I think it's helpful just to have that, or even at the time of definitive fixation, it's helpful, I think, to have some of those, adjuncts that are, I don't think you need stem cells. I don't think you need PRP or anything like that. But I mean, infection is a big problem for these fractures. So if you have tools as a rep that can help with maybe potentially reduce infection, whether it might be a wound vac or a, antibiotic cement, or I'm not using any of those things yet, but those like suture guard, that can maybe prevent a wound dehiscence. I mean, all those things I think are added tools that could potentially be helpful. We don't have all the data on all these things, but these are bad actors. So we're trying to, we almost like throw everything at them to try to, make us feel better at night.
Yeah, I think anything you'd have that would be helpful is relative for these cases.
And you can see here, one of the tenets is going to be an external fixator. So, I mean, and, sometimes even if someone puts a plate, fixes it with plates and screws, I still may want an X-fix on it. And I've done that for, soft tissue rest, as Nick mentioned, as well as for those anterior impaction injuries. I think it's helpful to keep a distraction on the joint for a longer period of time.
Yep.
And blisters, once again, wound care is key here. This is something, hopefully you don't see surgeons operate through these fields, because that's going to lead to really high infection rates and so forth. These are antibiotic beads, as you can see. When you're looking at a plate, this is bad. This is what you want to stop. In terms of the treatment, we want to talk about reducing the fracture first. And then, we get the restoration of articular surface. You need to bone graft. So you got to fill the defect. This is just like a plateau fracture, and so forth. In terms of, this is a, fancy X-fix here, right? This is a, multiplanar X-fix. usually used for like maybe an open pilon or one that's complicated by compartment syndrome. This is when we see this, that, you know, the potential of, you know, when you do a acute ORIF, so if you fix this acutely without staging, some studies have shown up to a 55% risk of soft tissue complications. And that's why we many times are going with a stage management is what we call it. So it's helpful to have those tools available, you know, especially if, you know, someone calls for a Pilon and they think they're going to fix it. Always be ready to have an X fix available, because maybe it gets too swollen, or, you know, the soft tissues are a little bit worse than were first advertised. Nick, are you acutely fixing anybody?
I used to, you know, I have less of that exposure now, but when I was taking more trauma call, I would fix them acutely.
Yeah.
Not everyone, obviously, but
Yeah.
there was cases that I did.
Yeah, I go back and forth, but a lot of times it also depends on just timing, because
Correct.
you know,
Yeah.
you got to give it all your all, and if you have other cases going on, it's difficult to
Yep. And
manage.
if it's a bad intra-articular one, then that, you know, is going to take a long time. That's one thing. If it's one that you think that you're pretty confident that you can get it pretty quickly, and you don't have a lot of other stuff waiting in the wings, I think it's a reasonable option.
Right, exactly. And here, you know, this is an example of a multiplanar X fix on a guy who had an open pilon here that I took care of, and bad diabetic, bad soft tissues, open injury, needed a flat medially. And this is where you can do sometimes some percutaneous screws just to get the joint kind of better to get, you know, not perfect, but better, and then span that area of comminution here. So, I mean, pilons are not only plates and screws, they can be, you know, spatial frames or a multiplanar external fixators, LRFs, and you know, some percutaneous fixation as well. So there's a lot of different treatments here. Here we talked about the stage X fix and ORIF. The reason why we do it is that the stage X fix have lower soft tissue complications, and that's you know, that's the main reason. It's lower, you know, because the tissue is the issue. So Nick, are you a fan of fixing the fibula right away and the initial trip to the operating room, or not?
Well, I think it depends if I'm managing it. If I'm on call and I'm not going to be managing it for whatever reason, then I will not fix the fibula. Most of the time, if I'm managing it, and again, my call looks a lot different now, but if I am managing it from beginning to end, I will think about fixing the fibula. The other question I have with some of these staged is, you know, these cases that have a posterior component that you want to fix or buttress from the back. So I have a few cases in which I would fix the posterior piece, and maybe fix the fibula, and then come back at another date to fix from the front. I don't know how you approach those, and
Yes.
if that makes sense or if that's helpful.
I think it's a very helpful, especially if it's a large, like posterior malleolus or something, you do a posterior medial approach. The other reason, and I think as a rep in the room, if you notice that they're sometimes, you know, struggling to get a reduction with an X fix, and it's a simple fibular fracture, so it's not like just destroyed comminuted fibula, but many times if you get the fibular out to length, so if you can plate a simple fibular fracture, it will help with the reduction of the tibia. And it makes your X fix much stronger, because now you not only have pins and bars, but you have a fixed broken bone, or a bone that's no longer broken. And so it's a key thing to remember that can help somebody, you know, in the operating room to gain the length alignment rotation, is to actually fix the fibula. And what's the question here, Corey? Is it reasonable to nail the fibula on site with the X fix? Yeah, I think if you can get the fibula reduced, Corey, I think it's
Yeah.
You know, I don't do too many fibular nails, but I mean, you could use a fibular nail, you could use a fibular screw.
Yep.
There's multiple like things that you could use to, you know, I guess place an intramedullary device in the fibula. So yes, if you can get it reduced and you know it's reduced, that's the whole key thing. You have to know it's reduced well.
And not just reduce, I mean, and this goes along with that, but you got to get that fibula out to length too, because a lot of times that there's a lot of comminution, and sometimes those are pretty tough to manage. The other thing that I've used, and I don't know if you use this, is like an intermedullary guide pin for
Yeah.
a fibula like you're showing there. So something just to give some stability to the fibula can be an option as well.
Yeah, so here, this is an example of an external fixator, what it can do. And this is obviously, this is not an ankle fracture. I think all of us can see that right here. But this is in valgus, right? The foot or the ankle wants to go to the outside. And then you can see here, when we get it out to lengthen in an X fix, it's in a better alignment. It's no longer, maybe it's a little bit of valgus, but it's not bad. It's much improved. This is a fibula you should not fix, especially on the day of injury. I mean, fix at least proximally, because you're never going to get this perfect. It's comminuted here. It's comminuted here. This is something you do not want to fix the fibula right away. So, but the goals here too, you want to improve the alignment. You want the talus, and this is what we're always looking for. And I'm pretty neurotic about it, is getting the talus in the right position. So you want to take, it helps one with soft tissue swelling, which will help you eventually do definitive fixation. And you want slight distraction as well, because you don't want this short, because if you X fix something short, it's very hard to lengthen it later on.
Jan, do you have any tips for gaining stability if you're in the room in the middle of the night and something like this? There's a lot of comminution. It extends. The zone of injury is pretty long. Any tips? You mentioned already plating the fibula. That might be a helpful thing, but adding additional pins or going into the midfoot. How do you decide when to add that stuff in?
Yeah, so I will definitely, I have no problem, like you said. So to strengthen an X fix, it's simple. Remember, we're simple people. I always tell the residents and the medical students, like, so if you add more pins, right, it's going to make something stronger. If you add more bars, it's going to make something stronger. So, add more pins to the foot, add more pins to the tibia. You can actually add a pin to the talus too. It's extremely powerful to add a pin to the talus. Because you have control over that bone directly, not just through the calcaneus. So yeah, more pins.
What size pins are you putting? So if you put one in the talus and you put one into the cuneiform, what kind of pin, what size pin are you using? I'm assuming you're using like a 5/0 in the tibial shaft,
yeah,
and 5/0 for the calcaneus. But then what are you using, 4/0, or is it smaller?
I'm using 4/0
okay.
For those things. So, and the set I use it goes from like or actually there might be even some 3/0s too. But it ties up directly with the regular X fix, because some companies, you have to call for like a large X fix plus a compact X fix, but there are some that have, a little bit more universal pins that you can use that are smaller, but allow you to tie into the foot, for example.
Yeah. So I think the point is, for those, that Delta frame works really well for a lot of things, but if you need to add stability, just know what your X fix has, so that you can kind of present the options that are there.
And then, the Stu asks, if you have a lot of comminution, what are you using to address your length? So great question. So you're looking at the fibula, first of all, to see if you look at the more simple fracture pattern to see if that looks like it's out to length. Like you could see here the bone ends here and then here. So that's just, maybe a little bit short. And then you're also looking here at the distal fibula and the relationship to the talus. Right here, I'm sorry, and how that's fitting in, just like you would for an ankle fracture. So those can be very helpful keys. I'm also looking just to make sure that I don't greatly over distract, because that can cause just more, sometimes more soft tissue swelling as well. So part of it is just gestalt, like, make sure it looks like a leg, and you can always come back in a couple of days if you need to readjust your external fixator for these bad injuries. That's not necessarily a bad thing, or, it can happen. So, I don't know, Nick, what are you doing to address your length and so forth during the case?
All of those things I think are helpful. You can always get you can get contralateral films. Sometimes that could be helpful too if you think about it beforehand.
Yeah, no, exactly. I think that's any of those things. You're just kind of using any markers you have, but once it's not a perfect science.
Yeah.
And then, fixing the fibula, like I said, advantages, improve stability of the frame, because remember, one bone is now no longer broken, it's fixed. And it helps, it's the indirect reduction, which is key here. So like, if you have fibular plates, you may want to ask if they're doing an X fix, are you going to fix the fibula or not? Some surgeons will, some surgeons won't. It just kind of depends on their, one, on the fracture type, but also if they're going to be definitively treating it. Because you just do not want to malreduce the fibula, because if I've taken down fibulas that have been fixed by others, because if it's malreduced, I can't get the tibia correct. So,
and then your point on the incisions is a big thing. That's why I think the general principle is if you're going to take care of it and manage it, then you can plan out your incisions based off how you feel it needs to be fixed. And if somebody else fixes it, they might burn a bridge that you can't get back over.
You're right, exactly right. You don't want to burn a bridge for somebody else. You're already dealing with bad soft tissues, and you don't want to just kind of make it even worse. And here you can see if there's some recurvatum or procurvatum. Like here the fibula is not directly reduced. You can see how it's angled, and this can cause a problem later on when you're trying to reduce the tibia. So even its slight malreduction matters. So if you can't get it right, just don't do it at that time.